brain stimulation and responsive neurostimulation. The responsive neurostimulation is not available at present in India. So, which surgery is appropriate for my patient? So it depends. So what the seizure is being caused. So if it is a perinatal insult, it's a local lesion, a tumor. Based on that, where is it located? If it is located in eloquent area, we don't remove it. We may not be able to remove it completely. Then we go for a lesser neuromodulation options. So I'll iterate some of the cases to see like how the management changes. This is a 13-year-old child with seizures for 3 years, and the locus was right temporal. So this is a very classic and common pathology in case of drug refractory epilepsy is a mesial temporal sclerosis. In this case, it is right mesial temporal sclerosis. We did right temporal, anterior temporal lobectomy and amygdalo-hippocampectomy, and the second case is a 9-year-old male child. Again, the duration of seizures is like 5 years, and he had a temporal onsets with a speech arrest. The speech arrest will denote on the left side usually. So this is a tumor-related surgery. So there is a large tumor involving the amygdala and the hippocampus. The same case we did with the same anterior temporal lobectomy with the tumor excision under ECOG guidance. So in this case, we opened big large because the tumor was extensive. We need wide exposure. So this is another example for a small focus. This is a 34-year female with 8 years duration of seizures with a localization to left temporal neocortical. So this was small video. So there is a small focus where the arrow is shown. It is a calcified granuloma. This is the vein was there, the vein of Labes, which is major one. There is a PET hypometabolism in this area. This is around 3 mm in measurement. So this was surgery. This is the vein over that particular this thing. This was a pre-op echocognitive recording, and this is a very small lesion. So you can say that was causing the seizures. And after removal, we did ECOG recording again, and we extended resection a bit more positively anteriorly and preserving the vasculature near that lesion. And say seizure free. This 6 months ago we operated this patient. This is another patient when the epileptic focus is there in the eloquent area. This is a 9-year-old child with a drug refractory epilepsy for 5 years. And he had many clusters and he was on multiple anti-epileptic drugs. So he had a epileptic focus on the postcentral gyrus, which is a sensory cortex. So these are the MRI. So this T1. This is a PET, so you can see the significant PET hypometabolism. And whenever we see workup for epilepsy patient, these 3 things should be concordant, like anatomically on imaging, electrophysiologically on EEG, and clinical semiology. So we are fitting this another video. So we went ahead with the surgery. So this is identifying the lesion, because most of the times we won't be able to identify the FCD on the surface. So some of them there will be sulcus, bottom of the sulcus, we don't see it. So this is the motor cortex and HANAP. This is the sensory cortex. This is a motor stimulation we are being used to confirm the motor area. And then we did echocorticography. And this is the area of abnormal we find on the echocardiography. So then we did resection. So this is a post-resection. And the patient was on the immediate post-op. He had some weakness in his left hand. And this is after like 2.5 months later. So his weakness has improved completely, and this is going to the school. This we operated 14 months ago. He's seizure free now. He's going to the school. So this is another case of functional hemispherotomy, like Dr. Harni demonstrated. This is a perinatal insult where we disconnected one hemisphere from the rest of the thing. This is a perinatal, large area of perinatal insult, and we did functional hemispherotomy on that side. She had right-sided weakness. So So this is the patient status. If you just look at the face of the patient, we'll understand how sick look she was. She was having epileptic encephalopathy and drug-related side effects before surgery. This was her condition. So the surgery was done, and post-surgery, after intensive physiotherapy, she's almost back to the normal. So such good results are possible with epilepsy surgery if appropriately evaluated and the earlier possible. So this is another type of hemispherotomy which we did in when I was doing fellowship at AIIMS, which is much less invasive than open surgery, which is a robotic surgery. This was first described in the literature. So when I was in epilepsy fellowship, we did around 6 cases. Now they have reached up to 30 cases. We'll show some of the technology. So this is another patient, is 18-year male with 14 years of seizures. See, the duration we have to understand. Both the parents are doctors. Father is a surgeon and mother is a gynecologist. Still, there is a delay in getting a proper treatment. So he had multiple types of semiologies, and he had a bilateral occipital gliosis. So this is, we did corpus callosotomy for this patient, and see, he is performing in his family function, and even is playing as a drums. So this is another patient. It's a 19-year male again. So 14 years of duration with a multiple drop attacks. These patients, they didn't want corpus callosotomy. So there are occipital gliosis again in the same patient. So this is, we did vagal nerve stimulation for this patient. This is a vagus nerve, and this is a lead over the vagus nerve, and this is a battery generator. This one very interesting. This is the videos are two different patients. The first patient we operated, the boy. So there was abnormal cry in one patient and abnormal laughing in other patient. So both are like gelastic seizures in the one, the abnormal crying is a diacrastic seizures in the other. So this patient had hypothalamic hamartoma, which we operated. He had no other endocrinology abnormalities. The hormone profile was normal. So in this patient, we did something called robotic radiofrequency ablation of the lesion. As the lesion is located very deep inside the brain. So previously we used to do open surgery and endoscopic surgeries, and it is very difficult to know abnormal tissue when we reach there. So this will give us better anatomical delineation in the MRI, and we can do it very easily. So this is a planning, the 4 trajectories, and we ablate it. This is the infrastructure, the robot and other things. So this is the incision that we made for this patient. So if you see on the second diagram, there was a small opening in the craniotomy, very small opening, around 3 mm opening, and through which all the trajectories will go and burn it. So this is the area of burn in the center, and this is scar, and this is a child. It's been 2 years. He still had some intermittent aura. So this is similar case to the hypothalamic hamartoma. This is periventricular nodular heterotopia. There is extensive periventricular nodular heterotopia from the atrium to the temporal horn completely. So in this case also we did same radiofrequency ablation through the robot. So this is the ablation. If you see the dark areas where it is ablated, the clear demarcation and not much extending into the white matter. So the vision, it is very near to the optic radiation, and the patient had preserved vision after surgery. So this is the scar, the central one. These are the other injuries obtained by the seizures. So what if the MRI is negative? So that is more complex. So we record directly from the brain, or we put the depth electrodes and do the surgeries. I'm not covering into it. So the epilepsy work or the epilepsy surgery is extensively teamwork led by the epileptologist, and it needs epilepsy surgeon, neuroradiology, and everyone trained, and needs also robust infrastructure as well. So this is our team led by Dr. Jabin and other epileptologists, Dr. Vamsh and Dr. Prashanti. To keep main points to keep in mind are like the refer early. So earliest referral is the patient, it saves the patient cognitive development. The seizures can be cured properly in a selected patients. They have to go a thorough evaluation before going for a, it has to be evaluated by trained epileptologists before going for a surgery. The risk associated with surgery with the current available technology and the expertise is very minimal. If it is appropriately chosen, it is excellent results. Thank you.
Yeah. Thank you, Dr. Raghu, for a very insightful session on surgical frontiers in epilepsy. Now, I request Dr. Sivan Narayan sir to kindly come forward and felicitate our invited speakers, Dr. Sai Satish Kandraju and Dr. Raghu Samala. I invite other panelists to please join him. Dr. Sai Satish Kandraju and Dr. Samala, please accept our token of appreciation. Thank you. Now we'll move ahead with the next session. I request Dr. Vasanta and Mrs. Pooja to continue with the next session. I thank all the panelists for their enriching and interactive session. Thank you one and all.
Good morning, one and all, to be here for the NeuroNexus 2025. I invite, we feel immensely proud to welcome Dr. Kumar Velu sir, Consultant Senior Neurologist, Acute Stroke Session, to give a talk on acute stroke session. Sir, please come on to. Sir, Dr. Kumar Velu sir, please come on to the dais as a moderator to give a talk on acute stroke session.
I request the panelists for the stroke session to come on to the dais. Dr. Sailaja PN ma'am, Professor Sri Chitra Tirunal Institute for Medical Sciences and Technology. Dr. Pramod Chalasani sir, Consultant Neurologist, Lata Super Specialty Hospitals, Vijayawada. Dr. Satyanarayana M sir, Associate Professor, Neuro and Interventional Radiology at NRI Academy of Medical Sciences. I request Dr. Shiva Prasad sir to come on to the dais for the case discussions in acute stroke session.
Good morning all. Today I am going to present 3 different case scenarios of acute ischemic stroke. The first case scenario, this patient is a 64-year-old man, is a normotensive with history of poorly controlled diabetes mellitus. He came with complaints of sudden onset of tingling sensation and weakness of right upper limb since 2 p.m. on the 7th of May this year. The weakness of right upper limb and lower limb progressed with a difficulty in speaking and comprehension since 4 p.m. But he arrived to our ER at 6:45 p.m. So onset to arrival is more than 4.5 hours. On examination workup, the pulse was regular. His BP was high, 155 millimeters mercury. NHS score was 9, HbA1c was 8.3, LDL was high, 132 milligram per deciliter. So MRI brain with angiogram was done. So DWI showed restriction of diffusion in the left MCA territory and also in the border zone areas of left MCA and PCA with a reversal in ADC. So in the flight, there was no hyperintensity in the corresponding area. There is clear DWI flare mismatch. So MRI brain angiogram was done. This shows MRI time of flight sequence showing no evidence of any large vessel obstruction. So diagnosis was acute ischemic stroke, left MCA territory, out of window period is a diabetic hypertensive de novo. The onset of symptoms to arrival is more than 4 hours 45 minutes. So the next step was in view, as there is a clear-cut DWI flare mismatch, thrombolysis was done. The patient had significant improvement of the neurological deficit. The NHS score after 24 hours after the procedure improved from 9 to 3. Next case scenario. This patient is 37-year-old male, is a hypertensive but not on any medication. He came with complaints of slurring of speech, deviation of angle of mouth towards left since the evening 7:30 p.m. on 27th of February last year. It progressed to right hemiparesis, global aphasia. He also had one episode of seizures by 11:30 p.m. Actually, this patient was referred from a private hospital at Ongole. He was brought to our hospital at 11 hours on 28th of February. So the onset to arrival is approximately 11 hours. Examination workup, airway was secured at the previous hospital with after one episode of seizures. He was on midazolam infusion. The pulse was regular. BP was 150 by 90 millimeters mercury. Pupils are equal and reactive. Plantars are mute. LDL was 87 milligram per deciliter. MRI brain plane showed restriction or diffusion in the left MCA territory with reversal in the ADC. So, flare also showed hyperintensity in the same corresponding area. So, we did a CT angiogram brain. This showed a bilateral non-visualization of bilateral MCA M1 segment. We also did CT perfusion study. Here we can see significant salvageable penumbra with increased mean transit time and increased blood volume in the penumbra region compared to infarct. So mechanical thrombectomy was done as there is a significant salvageable penumbra. He underwent DSA. Pre-procedure we can see the left M1 segment cut off here, and after procedure we can see the he had got a grade 3 TC flow. Still we can see the significant stenosis here. Unfortunately, after 1 month he again came with same symptoms. So we did a stenting for the same patient at the M1 segment. This admission, he improved near total recovery of neuro deficit. He was able to comprehend also. The last case scenario, this is a 48-year-old lady, diabetic with a history of rheumatic heart disease. She underwent mitral valve replacement in June this year. Her chief complaints were sudden onset of slurring of speech, deviation of angle of mouth to right side since 8 a.m. in the morning on 27th of July. She had tonic deviation of neck to right side with stiffening of hands and deviation of mouth to right side for few seconds. Examination workup, the pulse was regular, blood pressure was 90 by 70 millimeters of mercury, NHS score was 3, PTNR was 2.37. MRI brain with angiogram was done. Here we can see the restriction or diffusion in the insular cortex, the DWI, and the corresponding ADC reversal here we can see. There was no hyperintensity in the flare at the same region corresponding to the DWI restriction area. So there is a definite DWI flare mismatch, but the thrombolysis was not possible because of the INR was very high. Here we can see the non-visualization of M1 segment in the time of flight sequence. Here. We also did a CT angiogram brain. This CT angiogram showed focal narrowing at the M2 segment, but even though there was a M1 segment occlusion in the MRI angiogram, diagnosis was acute ischemic stroke, right MCA territory, right MCA M2 segment occlusion, left focal aware ipsiversive motor seizures. So thrombolysis was not done in view of elevated PTNR, as she was already on tablet acetrom. She was managed conservatively with parenteral and oral anticoagulants along with antiplatelets. This is a case of medium vessel occlusion. I now invite Dr. Kumar Velu sir to continue the session.
So thank you, Doctor, for the very good presentation of 3 cases, all of different scenarios. Just 2-3 comments I would like to make. One is starting from the last case, which you have shown. Definitely it's a medium vessel occlusion. This usually happens, I think we all should be aware when we are doing MR angiogram. Is your standard protocol of doing the imaging, we have to always understand that MR angiogram always gives some wrong information with regard to the vascular imaging. One is, sometimes it may be a tight stenosis of the M1, which will be seen as an M1 occlusion, especially if the patient is an ICAD. And in those patients, definitely we need to go ahead with intervention. But if you are planning and if you have a CT angiogram protocol, especially if you find that the deficit is very minimal and you have a patient referred with a M1 occlusion and you're having the patient is a NIHS of 3 or 4, and especially if you see the infarcts are like scattered multiple infarcts in that territory, always suspect it may not be M1 occlusion, maybe it is an ICAD, which is seen as an overrepresentation of the occlusion. Second is, we cannot rule out, especially if a patient gets transferred from another hospital, clot migration is very common. Even without thrombolysis, we may think that only thrombolysis produces migration, but even otherwise, we have seen patients with CT angiogram who is having a M1 occlusion. By the time when you do the angio, you find that there is a migration of the thrombus to the more distal vessel. In those last patient with medium vessel occlusion, there are 2 schools of thought. We know that the current 2 medium vessel occlusion studies are definitely negative with regard to managing them with medium vessel occlusion patients. But probably in that, because medium vessel occlusion includes a big group of patients, starting from the M2 proximal to the M3 patients were also included in that study. So in our institute, when the patient is having a M2 occlusion, if it is a dominant M2 or in situation of very proximal M1, and you find that the core is very small, and if you have an expert interventionist, you need expertise rather than a beginner. In those situations, we can still consider medium vessel occlusion. Especially if the vessel is not very tortuous and it is a difficult procedure, definitely we also do not do. But there is a select group which can still benefit from the treatment. So that is the one comment with regard to that. The first patient, I also totally agree. There was a diffusion. So the diffusion flare mismatch is mostly for wake-up strokes, but sometimes the onset, if you are not sure, in those situations, the diffusion flare mismatch is there. We already know the core is not there, so and the patient definitely needs to be treated with IV thrombolysis. Thank you.
Nice presentation, Doctor. Regarding the first case, which one you showed, the MCA-PCA watershed infarct, was a carotid or a vertebral Doppler done? Other than the MR angio, was a TCT done? Because the pattern of infarct looks like more like an ICAD infarct for me. It doesn't look like a distal block. So probably most of the times when we do an imaging, we might miss a floating thrombus inside a major vessel that produces the typical picture of the MRI with spotting and all those things. So that's one point I was thinking of. This is the second case. A angio was done, a CT angio was done, and you found a stenosis at this thing. Why didn't we went into doing a stenting at that point of time? Why did we wait for the second stroke to occur?
First time the attenders.
Oh, okay. There was just a problem with the finances.
Yes, they were not willing at the first admissions.
Okay. And yeah, please.
As regards the doing stenting in the acute stage, it is generally the latest recommendation is 2 to 14 days. One paper has come where they say that try and avoid doing it in the first 48 hours of an acute ischemic stroke, because the stent thrombosis or stent reocclusion is very high in the first 48 hours. Though the general guideline which we generally follow is 4 to 14 days, most of the intervention is generally prefer 4 to 14 days post acute stroke for doing a stenting.
You're exactly right, sir. But the point here is, it's an MCA severe stenosis, and the second time it develops, he might have a catastrophic event, and that might finish him off. So you'll have to look at the patients, and then probably other things, finances and other things, and then could take the call. You're absolutely right.
Can I also make a comment in this? As you know, if you look at all the endovascular thrombectomy, the most challenging to treat is the acute occlusion with an underlying ICAD. We have had experiences with all 3 levels of treating. But I think currently the guidelines do not say which is the right way to go. So there are 3 ways of treating it. One is after you do the thrombectomy, you see there is residual stenosis or there is keeping on reocclusion. These are the 2 situations we suspected there may be an underlying ICAD. So in those situations, one way is we usually do just a plasty alone. Sometimes it's a tight stenosis even after removing the thrombus. We just do plasty alone because it has to be decided depending upon that individual patient. If the patient has already got an aspects of a moderate sized infarct and that patient has received a bridging thrombolysis, we will definitely not be able to give a loading dose of antiplatelets, which is unlikely to produce definitely a bleed risk. But if the same patient did not have any thrombolysis given and you're doing an angioplasty, doing an angioplasty alone may not be enough for this patient. So in these situations, definitely from our PRAN registry also, which we are going to publish now, tirofiban infusion, and I think Dr. Vijay has got the maximum experience of these ICAD patients. In these patients, tirofiban infusion, we just do a plasty and continue with tirofiban infusion for the first 12 hours and then do a imaging and then load these patients with the dual antiplatelet. So I think currently we do not have any definite guidelines, but we also try to avoid stenting as much as possible in the acute phase unless it is a continuous reocclusion and there is no way to manage them. Thank you.
Regarding the third case, the INR was very high. Why not think of thrombectomy or something like that?
Medium vessel.
But still, it's a major area of the brain.
CT angio showed a medium vessel occlusion, and NHS score also was very less.
Madam has already told everything, so there is nothing more to add. We also do a first balloon angioplasty and give 10 to 15 ml of tirofiban, wait for 15 minutes, whether it is reoccluding or not, we see. And then if it is reoccluding, we try to put a metallic. Otherwise, we do is immediately after mechanical thrombectomy, we do a plain CT, see whether there is no bleed immediately, and then tirofiban infusion will go. And again, we do repeat CTs at a frequent interval, not like a routine mechanical thrombectomy. We do it immediately after balloon angioplasty and tirofiban infusion. After mechanical thrombectomy, we do an immediate CT. After 12 hours, between 8 to 12 hours, depending upon the patient clinical condition, we repeat a CT and confirm there is no bleed, and then we give dual antiplatelets.
So one small point, we can, tirofiban can be primed also. Like even before because when there is an acute event, we can start off the tirofiban and then do the thrombectomy and follow up as required.
I think that's a very good suggestion. If you pre-procedure, you know it's an ICAD, so then there is enough time for you to plan it also.
Whether it is a red clot or a underlying narrowing is there, we can get some imaging like plain CT calcific foci or on MRI, there will be blooming sign. SWS, it might not be seen in ICAD. So this will be of helpful to plan during whether to do a aspiration or a Solumbra technique. Even this imaging also will say whether there is an underlying ICAD or it is just a clot. This also will help for treatment planning, and then tirofiban loading also, that will help. Imaging will help, like in these situations.
Can I have the lights off?
Now I request Dr. Kumarvelu sir, Senior Consultant Neurologist at Aster Ramesh Hospitals, Guntur, whose dedication to the medical field is an inspiration to many, to speak on the topic Rewriting the Stroke Rulebook from Time Limited to Tissue Driven Thrombolysis. Sir was recognized with several prestigious awards and gold medals for outstanding contributions in neurology. Sir has around 36 national and international publications. Over to you, sir.
Thank you, ma'am. Now, having heard all the experts on the stage and their comments, I'll just briefly summarize in 6 headings what we intend to do in thrombolysis. We'll come with the first thing, beyond 4.5 hours thrombolysis. Systematic review and meta-analysis assessed whether altiplase/tenecteplase improves functional outcomes versus control in patients with acute ischemic stroke with an unknown time of onset or known time beyond 4.5 hours, guided by advanced imaging. The current guidelines, both European and US, recommend intravenous thrombolysis with altiplase/tenecteplase in patients with unknown time of onset if patients meet the wake-up criteria and when salvageable tissue is identified with imaging biomarkers. The authors of these studies completed a systematic review and a meta-analysis of individual patient data. I'll just quote a publication which came about 3 months in the New England Journal. There are 8 studies which are done in this line beyond 4.5 hours, namely the Wake-Ups, Extend, Epithet, and ECAS-4, all used altiplase at a dose of 0.9 milligram per kg. And the Japanese study, as you all know, Japanese study always uses a lower dose of altiplase compared to the rest of the world. THOS, which used altiplase at 0.6 milligram per kg, and 3 studies which are recent, which studied tenecteplase at the dose of 0.25 milligram per kg, Exit BT, Trace 3, and Bridge TNK. The purpose of this, the primary outcome was a favorable outcome by a score of 0 to 1 on the modified Rankin scale at 90 days after stroke. The secondary outcomes were functional improvement across the entire MRS spectrum at 90 days and independent outcome with the MRS of 0 to 2 at 90 days. Safety outcomes were 2, namely severe disability or death and symptomatic intracerebral hemorrhage. This is the latest study which I borrowed from New England Journal, which I quoted about the 8 studies that I said, and the point of concern is it analyzed data to the tune of 1,742 patients and over 263 centers involving virtually the entire globe. Control were more or less equally distributed. The outcome is excellent functional outcome at 90 days and good functional outcome was seen with a trend towards improvement. However, the study was not powered for studying the mortality and the symptomatic intracerebral hemorrhage, though they were mild elevation of both the same. Now, having heard these 2 studies, our conclusion is these individual patient data meta-analysis extend the evidence from individual trials and supports the use of imaging biomarkers to guide treatment with intravenous altiplase/tenecteplase in patients with stroke with an unknown time of onset. Now, coming to the next, a very hotly debated topic, namely, do we bridge or do we not bridge before thrombectomy? This is what they say is that the conclusion in that study, in the recent one, is bridging thrombolysis achieved better outcomes than direct thrombectomy after large vessel occlusion. It's an updated meta-analysis, and I'm very fond of quoting this. This is what was come in one of the New England Journal by an author. Thrombolysis before thrombectomy in stroke, a bridge not fallen as yet. What they did was, they did the analysis of all the patients that they had, and the current guidelines saying that bridging therapy in eligible patients presenting within 4.5 hours after symptom onset, it is recommended. And why tenecteplase scores over alteplase as of today is that it has a longer half-life, higher fibrinogen specificity, greater resistance to endogenous inhibition by PI, plasminogen activator inhibitor, and ease of delivery by a bolus injection. More or less, the world has switched over to tenecteplase from alteplase as of today. Intravenous thrombolysis should not be skipped in the treatment of large vessel occlusion strokes and acute ischemic stroke within presenting with LVO less than 4.5 hours after onset. The percentage of patients with functional independence at 90 days was higher with the bridging therapy than with DT alone. Now, coming to one small thing, as one was highlighted in one of our patients which was presented, thrombolysis in minor non-disabling strokes, the PRISM and Aramis trials, what they say is that thrombolytic therapy is not beneficial in patients with minor non-disabling strokes. That brings us to one question. We should know what is non-disabling and disabling. It all depends not only on the deficit that the patient has, but also on the individual's occupation. That makes a sense. So, any patient who has got NIHS of 4 or less, but which has got a significant impact on his day-to-day activities, which impacts his livelihood, it becomes disabling. That's a point that we should keep in mind. Now, this is one article I picked up recently when I was going through. It is influence on thrombus length. They say that intravenous thrombolysis done in patients who have got a thrombus length of 8 millimeters or more seem to have early neurological deficit post-thrombolysis, and hence the authors go to the extent saying that if the length exceeds 9 millimeters, it may not be prudent to do with IVT alone. You may, if there is a requirement, you have to go for mechanical thrombectomy. Now, thrombolysis with tenecteplase achieved better outcomes than standard medical treatment after large vessel occlusion in windows from 4.5 to 24. This is a bit, I may call it, at the moment, maybe a bit too much of a length of the tissue window, but this is what has come from the Chinese people. The article says that patients with LVO of the middle cerebral artery or the internal carotid artery who had salvageable brain tissue as identified by perfusion studies, be it CT or MR, where to receive and who do not have access to EVT, very definitely applicable to a country like India where thrombolysis is reasonably affordable and achievable, and EVT as of now is prohibited for the majority of Indian population by the cost, by the very fact, the availability of infrastructure and the cost thereof. Now, in such patients, they have done up to 24 hours provided they have got a salvageable penumbra. That's a point. As one of our last patient he showed, the second patient where there was a salvageable penumbra despite being late. They analyzed 516 patients, and the MRS of 0 to 190 days, which was a standard medical treatment, was significantly better. So, patients with a salvageable penumbra up to 24 hours are likely to benefit with intravenous thrombolysis. Now, mortality at 90 days was mildly elevated, but no statistical significance in the number that they have quoted. Symptomatic intracerebral hemorrhage was more, but the death rate was more or less equal between the two groups. Now, thrombolysis of posterior circulation, a topic which is rather untouched in most of the studies, is with alteplase in 4.5 to 24 hours. Again, a paper originated from China. With due regard, those guys produce phenomenal papers within a very short span. I wish India could do it. Randomly assign patients with posterior circulation stroke without extensive early hypodensity on CT and who have no plans for thrombectomy. Altiplase at the dose conventionally recommended and 4.5 to 24 hours after the onset of symptoms. 234 patients, 117 in each arm. Functional independence at 90 days was better. However, the incidence of symptomatic intracerebral hemorrhage was high and deaths were definitely less with the Altiplase group compared to the standard care group. Now we come to two untouched areas. These are all prohibited areas as far as most of our trials go, because none of these groups are included in any of the trials till date. In children, CT is fast, easily available to detect hemorrhage, yet its sensitivity to stroke within the first 6 hours is questionable. Coming MRI is sensitive, yet not always available and needs a cooperative child. And the minimum sequence most of us are aware, we'll skip that. CT angio, too much of radiation in a child. Catheter angio seems to be the gold standard, and especially when you have got a suspicion of small vessel vasculitis. Now this is one, sorry for this congestion, this has been borrowed from Boston Child Hospital, where it was published about nearly 9 years ago. When a patient is suspected to have stroke by the standards laid down, and you feel that the patient can be transported for an image, and the MR shows that the patient is likely to benefit from thrombolysis. This is the next slide, where you can see that I have said what we do is that diffusion flare mismatch with no evidence of bleed on the SWIP image, with a time of flow sequence showing no occlusion. Then if it is no evidence of bleed, go ahead and thrombolyze. That's what that hospital protocol says. Seems to be followed even in Australia, though we don't have a protocol of our own in this country. If it's a TPA candidate, the dose is the same. They have extended the adult dose to pediatric age group also. And what we do, our importance is you admit and give the thrombolytic drug. And here, once you admit, you have to maintain the blood pressure. The main criteria when we give thrombolysis in an adult, we have got defined criteria based on the systolic and diastolic blood pressure. Whereas for children, we need to be aware that it is much less than what is seen in adults. What you need is that the cutoff line, they say, is more than 15% above 95th centile for that age, which can range anything from 128 to 161 in female children and 129 to 161 in male child. And this is where we need to treat and try and get it below this thing. The treatment is the same as you can see there, it is labetalol, what we do in adult practice as well. Now we go to the last frontier, still to be conquered, acute management of stroke in pregnancy. Tissue plasminogen activator is a CAD-C agent in pregnancy. Its effects on humans and animals during pregnancy is not adequately studied and as of now considered to be contraindicated as per literature. However, what we should remember is TPA is a large molecule, and both TPA, altiplase and tenecteplase and altiplase molecular weight wise remains the same. Does not cross the placental barrier. So there is no question of teratogenicity when this drug doesn't cross the placental barrier. Now, there is no tumorigenicity seen in rodents and no mutagenicity has been seen even in human lymphocytes in rabbits. Now, there are 4 publications to date covering around 20 odd patients. Only 20 I could gather from the literature. What it says is good neurological recovery is seen in about 11 mothers, with one patient had intra-arterial angioplasty which led to dissection and the patient died along with the child in utero. The fetal outcome in 11 babies was good. In 2 early cases, medical termination of pregnancy was opted for and one child died with the mother. The current recommendations based on expert opinion, this is what we call as CAT-C EO, expert opinion, are that treatment decisions should be made balancing the natural history, that is prognosis without TPA and with TPA. You look at the complications and the beneficial effect of giving the drug in a pregnant mother. And use of IV TPA can be considered in a pregnant patient. The chief risk to the mother is symptomatic intracerebral hemorrhage, which is lower in individuals less than 60 years to the tune of 2.8% and can bleed elsewhere, which can be managed. To date, no demonstrated risk to the fetus, and iodinated contrast seems safe even in pregnancy, though it is supposed to be a CAT-C drug as of now. To conclude, ladies and gentlemen, my time is over. Imaging-based selection of salvageable brain tissue with a penumbra on advanced imaging techniques with a mismatch may benefit from IVT even beyond the 4.5-hour window. The time frame extension from 9, as of now the literature on RCT is only up to 9. However, if you try and take the Chinese study, we can extend it up to 24 hours in appropriate settings. Balancing benefits and risk is always to be considered by the bedside in consultation with the attendants. Imaging interpretation, careful imaging and rapid, most important, careful, rapid. That's why rapid AI seems to be having its way around. Though I think a good eye of a radiologist can easily give you the necessary information within the time frame. And of course, I'll request the Indian AI guys to come forward and create a set of our own where it becomes affordable to the medical population as well as which in turn extends to the patient care. That's important. However, this is very, very important. Gentlemen, time is still brain. We have got a tissue window where we are trying to extend, but still, even then, the earlier the thrombolysis, the better the outcome. Bridging therapy with IVT before EVT in eligible patients presenting within the treatment window is recommended. Tenecteplase definitely showed a better efficacy compared to alteplase. And thrombolysis with tenecteplase may be beneficial in select patients with LVO and no access to EVT, which happens in Indian settings very often. Posterior circulation strokes with no LVO may benefit from either of the two drugs. No thrombolytic therapy for minor non-disabling strokes. I use the word no, as of now it remains no, but only with a rider. What is disabling, not disabling, patient's occupation will decide. Thrombus length more than 8 millimeters, IVT may be not good. IVT in children, as of now, not evidence, but may be beneficial. And IVT in pregnancy is safe to the mother and fetus, may be considered in appropriate setting. So, ladies and gentlemen, we have come a long way ever since 1995 when the seminal paper on thrombolysis came into this world. Let not our stroke victims have such a bleak outlook. Let them have a beautiful roadmap ahead as seen in this slide. Thank you.
Thank you, sir.
With great respect and privilege, I invite Dr. Meena Chandra, passionate neurologist, to come forward onto the dais for the talk on MEVO, small clots, big strokes, to treat or not. And super specialty from AIIMS, New Delhi. She has done fellowship in stroke from AIIMS, New Delhi. She was awarded many gold medals and she won Young Investigator Award at the World Stroke Congress, Barcelona 2025. Very glad to invite you, Dr. Meena. Over to you.